Almost there. Okay, and we are live. Good morning, web shadowers. Thank you all for joining our session today. Today we have the pleasure of hosting Dr. Cather McKay, a dermatologist. As always, please remember the Google form will be posted in the chat box at the end of the session and also in our Instagram bio at the end. With that being said, Dr. McKay, you can get started whenever you're ready.
All right. Good morning, everyone. Thanks for joining today. So I gave a talk a few weeks ago and about dermatology. And so we will we'll do a couple different types of cases today. And so the focus will be on atopic dermatitis and psoriasis. Make sure this is up. Here we go. Okay, so on the second, I went into kind of how I got into dermatology, a little bit of advice for pre-med and med students, overview of the field of dermatology, the different subspecialties within dermatology, what it means to be a board certified dermatologist, and then kind of my day-to-day, work life. And then we talked about the anatomy of the skin and then did two kind of in-depth cases. One was a basal cell carcinoma and how from the process of the patient presenting all the way to being treated. And then same with the melanoma case. So if you didn't see that, if you want to take a look, it's on the YouTube channel. And I'm not going to go into all that again. I'm going to focus more on some cases today. All right. So today we'll talk again, just a refresher on the basic anatomy of the skin, a little bit about immunology that's involved with the skin, and then some cases. All right. So like we talked about last time, this is a cross-section of the skin. So this is the outermost layer, the stratum corneum, the epidermis, and within the epidermis, you have your squamous cells, basal cells, which are producing the squamous cells. They basically differentiate and go through this process where they mature and then turn into the stratum corneum, which is kind of like a dead skin cell layer that protects the skin from the environment. And then you also have your melanocytes. Basal cells and squamous cells are all types of keratinocytes, so that's another kind of word for those. So the epidermis is actually pretty thin, but there's a lot going on in it. Then you have kind of your hair follicles that dip down into the dermis. In the dermis, you have lots of collagen, elastin. It kind of gives the structure and support to the skin. This is where you have all your blood vessels, and there's a superficial plexus of blood vessels, also nerves. And then you have the fatty layer called the subcutis underneath the dermis, and there's kind of like little bigger blood vessels and a whole nother system of blood vessels and nerves down there. So that is the cross-section of the skin. And next, within all those layers, there's a lot of the immune system is super active. So of course the skin, one of the main functions is a barrier to the outside world. So it's constantly being exposed to bacteria or pathogens and, allergens and things that it has to figure out. Is this safe to me? Do I need to protect myself? So there's a lot going on at all times. The innate and adaptive arms of the immune system are kind of the ways you kind of think of the immune system. So the innate, and they're both super active in the skin. So the innate immune system is all this stuff that's just ready to go. So it's the immediate reaction that the immune system has to potential threats. So it has complement, toll-like receptors play a role, and those are on all your keratinocytes have those that are, so it's it starts like a cascade. So even the skin cells are part of the immune system. They have immune function as well. Inflammasomes, antimicrobial peptides, cytokines, macrophages, neutrophils, eosinophils, mast cells, and NK cells. So those are all active in the skin. And then you also have the adaptive system, which is more of like a memory forming system where the antigen presenting cells in the skin, they're called Langerhans cells. Those are in the epidermis, kind of sampling different things that it finds, and then it kind of reports back to T cells and B cells, both in the skin and in the lymph nodes, to trigger an immune like cascade and pathway, and if it needs to mount immune response, all those things come into the skin. So it's super complex. This is just a little pretty simplified version of what all is involved. So again, you remember you have your epidermis, basal layer in the dermis. So in the actual epidermis, you have these Langerhans cells kind of hanging out, waiting to see if anything, it's exposed to anything. Your T cells can come to the epidermis. Most of these things are kind of in the blood vessels or dermis, and then once the signaling cascades start, they get recruited to the area. So you have lymph vessels and blood vessels all in the dermis. You have your dendritic cells, macrophages, different types of T cells, NK T cells, mast cells, fibroblasts. These are all, this is a little bit more detail, but it's still super simplified. I like this diagram because it kind of shows the keratinocytes themselves are doing, have immune functionality as well. So they're at the very, here depicted here on the outside, defensins, cathelicidins, those are called antimicrobial peptides, and they part of the innate immune system. You have your toll-like receptors, your major histocompatibility complexes. All this is kind of in place, ready to go. And if there's a threat or a trigger, then you get this cascade that triggers the adaptive immune system. And so, like I said, your Langerhans cells, once they are stimulated by an antigen, then they can go and prime a T cell. So you have your T cells that then differentiate into Th1, Th2, and actually Th17 is another type of T cell that's important in the skin and in kind of the immune mediated conditions that we see. So this is all, we've, in the last several decades, we've really, it's been incredible how much they've figured out about all the molecules involved. And then it's important to know this because then you can target these things when you realize, oh, this is certain things are upregulated in, say, psoriasis or atopic dermatitis. Well, now we have medicines that can target those. So it's pretty remarkable, everything they've figured out. And that's what I love about dermatology. There's so much immunology involved. So then, and this kind of depicts, it's not to scale, of course, but within your blood vessels, you have, everything kind of ready once something starts happening in the epidermis or the dermis. Well, then your blood vessels actually start to express certain receptors that then kind of grab on and say, hey, like I need whatever cells to come in and help us out. So anyways, this is simplified, but still pretty like a little bit more detail about what is going on. And this is all happening constantly all over your skin. So pretty cool. Okay, so with that little bit of background, we can go into some cases. And this is what we'll do for most of this session. Okay, so you get to clinic and your nurse or medical assistant has your first patient ready. And like we talked about last time, generally in a clinic setting, you have your nurse or medical assistant room the patient. So patient has filled out their paperwork and with their history and their medications and whatnot. And the nurse or medical assistant goes in and kind of talks to them a little bit, gets their reasons why they're here and a little bit of information. They come talk to you. So then they say, Daniel, so Daniel's your first patient. So he's a 4-year-old African-American boy. He has a history of asthma and he presents for a worsening itchy skin rash on his arms and legs. He's had rashes since he was about 6 months old and his pediatrician has been able to treat them, but lately the treatments aren't working as well. All right, so we'll kind of break this down a little bit. So he's 4 years old and he's had this rash since he was about 6 months old. So this, that's chronic at this point for most of his life. So when you're already starting to think about what this could be. And, when it's ongoing for that long, it's something you're lower on your list is like, well, this is something that he's come in contact with or whatnot. Probably not, it's something that's going to be a chronic condition. So he has history of asthma. So that tells you a lot. There's, we'll talk about something called atopy, but asthma, allergies, eczema, all that kind of often run hand in hand in the same patient or in families. So worsening itchy skin rash. And this is pretty common that as a specialist, the pediatricians or internal medicine or family medicine doctors are often, the first line. So they'll treat, especially pediatricians, because kids get a lot of skin stuff. So they'll treat to the best, that they know and do. But once it gets out of hand and what they're doing is not controlling it, then they come see us. So usually they've had certain treatments they've tried before. But something's happening lately, and really the medicines that he's tried for the last, since he was 6 months old aren't working. So you look over his medical history, his meds, his allergies. That's usually all like in the computer by the time you're ready to see the patient. And then you go in and, of course, with kids, you're mostly talking to the parents. They can tell you some stuff, but usually they're like running around and not really paying attention. So you talk with the mom and get more information or dad. And again, that's called the history of present illness. So the HPI is what we call that, what you do first. So getting the information from the patient. And they usually, if you ask the right questions, they can, oftentimes you can know what's going on just by talking to them. So he's always had dry skin, but really rashy, off and on since the age of 6 months. Very itchy. It's keeping him up at night. And this is a key question in kids. There's a lot of evidence that shows, when skin conditions or itching keep them up at night, then they can have other developmental issues. Sleep is really important. So, and then when in the skin, itch is can be a huge burden. So that's always asked about, is it significant enough to keep him up at night? And that usually is like, makes it harder for the mom and the whole family. And he's also having some pain of his right ankle, and that's kind of different. So that's important to note. And then he's been prescribed hydrocortisone 2.5% cream, and that's been helping a little, but it's really not controlling everything. And so in dermatology, you'll learn, the different strengths of topical steroids. There's different classes and more potent and less potent. And hydrocortisone 2.5 is a pretty mild, kind of weaker topical steroid. So, in the fact that it helps a little tells you, it is that, I usually think, okay, it's an inflammatory condition if the hydrocortisone helps some, but probably need something stronger if it's not taking care of it altogether. Okay, and then you go over past medical history. Just again, you do know he has asthma, and you ask a few more details. And he needs his albuterol nebulizer a few times a year. Maybe if he gets a cold or something, his asthma acts up and he needs the inhaler or the nebulizer. So that's usually, of course, managed by either the pediatrician or sometimes allergy immunology. And then his mom has eczema. So that's important too, family history. A lot of these things, while we don't always identify one gene or an exact, we haven't identified that yet. I mean, we might at some point. There's some genes that we have identified make you more predisposed, but you see a lot of things run in families. So we're still kind of sorting that out. But family history is important with skin conditions. And then you kind of just ask a few general questions, and that's called the review of systems, when you kind of go through other things. So we're in dermatology, of course, focusing on the skin, but you kind of, at times, you ask pertinent other questions like, well, has he had any fevers or chills or malaise? Is he otherwise feeling and acting okay? And he is. So she says, he's nothing else really out of the ordinary. And then in kids, I usually ask like, okay, are they growing okay and everything? The pediatrician doesn't have any concerns about growth or development. Okay, so then after you talk to the patient, then of course the physical exam is the next thing. So in general, kids, they don't overthink things. So you can tell a lot by just looking at them. Are they feeling okay? Are they running around? Are they active? Are they kind of like, when they don't feel good, they're not good at hiding it. So in general, Daniel, you see he looks good. He's, has good hygiene. Looks like a normal weight for a 4-year-old. He is active and he's actively scratching. So I always kind of try to take note of that. Like, he probably can't control it. He's itchy. So you see him just like scratching away. And then we look at his skin. So we'll go through that. So you start with the face. In general, he just kind of has dry appearing skin, and that's called xerosis. That's the medical term for dry skin. He also has this thinly scaling eczematous hyperpigmented plaque around his mouth. And if you look, you can see these kind of more subtle hypopigmented patches throughout the face. So anytime there's inflammation in the skin, you can get pigment changes, and sometimes it's hyperpigmentation and sometimes hypopigmentation. And these patches, we'll talk about what they're called, but those are things that you note on his face. And then getting to his back, this is called follicular prominence. So if you felt that, it would feel bumpy. So it's each little follicle is just prominent, and it kind of gives this like the bumpy appearance. And then you see also some erythematous. So you can see some red in here, but also violaceous or hyperpigmented. So violaceous is, obviously a purpley hue. So oftentimes on darker skin types, red is not as prominent, but maybe it looks more purple or hyperpigmented. So that's the way you can describe that color. And lichenified is another word we use in dermatology, and that means that it's thickened, like the bark of a tree. Is, I think, the derivative of lichen, like lichenified. And that is a sign of its chronicity. So when things in the skin are chronically rubbed and scratched, I always describe it to patients as like your skin is thickening and trying to protect itself. So when you see that lichenification, it's a sign that it's been there a long time. He's probably itching and scratching at that spot in particular. And you can even get into where when you're scratching and something gets lichenified, it's kind of like an itch scratch cycle. So the more you scratch, the more it itches, and it just kind of like feeds itself and gets out of hand. So those can be pretty, just pretty uncomfortable for the patient. Okay, then you look at his arms and legs, and in his, so here you can see the erythema, and if you felt it, it would be slightly palpable, like a little bit raised, and so this would be called an erythematous eczematous plaque, and that's the antecubital fossa, which is like the bend of the elbow. And then on the backs of his legs, hyperpigmented, so this is hyperpigmented compared to his normal skin color. Lichenified, because it is more of that rough, thickened skin. Eczematous plaque, and this is the popliteal fossa. That's the bend of the knee, behind the knee. Okay, and then you get to his lower extremity. Remember from the history, it's painful. So when you get down there, you can see it looks different than the rest of his skin. So you have, these are called erosions when you lose that top, part of the epidermis. So it's open skin. Some of these, it's hemorrhagic crusting. So it's been, has bled and the blood has dried and whatnot. So it's got some crusting down there. And then, it's probably, you don't know if you can tell in the picture, but he does have underlying eczema kind of under all of this. These are all secondary changes on top of his eczema. Okay. So, well, sorry, I gave it away, I guess. Does anybody know what this is called? I guess even like the medical term for what this patient has. And actually, he might have a couple of things going on. So if anybody, I have my chat box open. I know there's a delay, so I'll give you all some time to see if you have any thoughts on this patient. Eczema, atopic dermatitis. Good. Yes. So eczema is kind of the layman's term for an atopic dermatitis is the medical term for what eczema to a dermatologist is a very nonspecific term. There can be a lot of things that cause eczematous rashes. And so if you say atopic dermatitis, that's more specific. That is, an intrinsic, intrinsic eczema is maybe another way to put it, but it's more, what this patient has. So it's chronic, ongoing. It's his, probably in his genetics with his family history, so that is the, yeah. So yeah, there we go. Eczema, AKA atopic dermatitis. So when I talk to patients, I use the word eczema because they understand that better. But technically the diagnosis is called atopic dermatitis. You could also consider other things. So again, this is called a differential diagnosis. So when you see a patient for the first time and you're thinking through what it could be, that's a differential diagnosis. So other things you could think about. I mean, this is a pretty clear case of atopic dermatitis, but irritant or allergic contact dermatitis. So you could think about that. The way that his is distributed and it's all symmetric, and the other signs that he has, like on the face that we're going to talk about, those all point more towards the intrinsic atopic dermatitis. Now, patients with atopic dermatitis can have secondary, they're more prone to developing irritant or allergic contact dermatitis because their skin barrier is not intact. So allergens get in more commonly. Tinea corporis is the name for skin fungus, but the way that this is so widespread wouldn't fit with that really, and the time frame and just the way that it really looks. But they can again could have multiple things going on at some point, but that this doesn't look like fungus. Psoriasis is another consideration, but it's the way that the skin looks is more eczematous, so it really doesn't look like psoriasis, and we'll go through that next. But kids can develop psoriasis early, so that you still have to kind of think about that. And then bacterial skin infection. So this patient also does have on that ankle a bacterial skin infection, which we'll talk about. So his assessment would be atopic dermatitis, secondary bacterial infection, so impetigo, and that's on the right lower leg, or impetigenized is another way that, impetigo can be just a primary skin infection, super common in kids, but when eczema gets impetigo on top of it, it's called impetigenized. So it's secondary to the eczema, and kids are scratching and their dirty fingernails or whatever. Kids with eczema are very prone to bacterial skin infections. And then pruritus. So we'll that kind of goes along with the atopic dermatitis, but we will talk a little bit about that. Okay, so pathogenesis. Why does atopic dermatitis happen? There's three main components. There's the impaired barrier function, immune dysregulation, and then you also can have environmental influences. So our skin barrier, when for patients with eczema, there's issues with sometimes there's certain protein deficiencies, or like filaggrin. It leads to abnormal adhesion of the and corneocyte. So the stratum corneum formation is abnormal. There's more proteases. Can be abnormal lipids. So there's a lot of proteins and lipids involved in creating an intact stratum corneum. And when it's something from a genetic predisposition or whatnot is impaired, then you can get an impaired barrier function. This stands for increased transepidermal water loss. So our barrier also keeps water and hydration in. So when it's not intact, you lose a lot of that hydration, and you just constantly have dry skin. But that's a big component of atopic dermatitis. You also have immune dysregulation. So both innate and adaptive responses to environmental stimuli can be dysregulated. So we believe that, or the current understanding of atopic dermatitis is that it's more of a Th2 response. So you have increase of IL-4, IL-5, IL-13, IL-31. And so that leads to a lot of the types of inflammation. And we can target the receptor for IL-4 and 13. And we're kind of developing drugs for IL-31. So knowing this pathway has allowed us to develop some really good medications. And then more chronic, sometimes it converts to a Th1 or Th17 or Th22 response. So the adaptive immune system plays a big role in this. And environmentally, so you have increased penetration across the skin barrier. So irritants, allergens can get in more easily. And then they, further activate the immune response and cause more inflammation. The skin microbiome is important. So you get changes, more Staph aureus and less Staph epi. So it's the microbiome gets skewed, and in patients with eczema, allergens, and irritants. So lots of factors at play, and knowing the pathogenesis, then you can treat, the way you treat it. We're kind of going to try to address each of these components. And then eczema can present differently in different ages. And if the same patient, most often it develops in childhood, but there are some times when it develops in adulthood. So kids, and usually, it takes them about 6 months or so to get going. They might not have signs of eczema super early, but maybe around 6 months or so start developing rashes and itching. And kids, the face is often affected, skin folds and extensor surfaces, their neck, because their neck is so, there's just they have a little short neck, and so all that moisture and irritation under there, they can get it. The neck is more prominent. Child, still a little bit on the face, but that usually gets a little bit better with time. But then it can, as they grow, they're getting it more on their flexural surfaces. And then in adulthood, it's often, sometimes kids with atopic dermatitis, it can get better with age. We never promise that, because it doesn't always. Sometimes it persists, and sometimes it stays severe even as patients get older. But a lot of times it gets better, which is good. Good, giving the parents some hope, but can't promise it. And sometimes kids with eczema turn into adults with, say, just hand eczema, or just limited issues, or eyelid dermatitis, or things like that, when there's sometimes just a small sign of it later in life. Okay, so associated features. If you're ever questioning your diagnosis, you can look for other findings. So just start from head to toe. So Denny Morgan folds, these lower eyelids, just from chronic irritation and rubbing and whatnot, that you get this hyperpigmented fold and the puffiness in the eyes. Periorbital darkening, so allergic shiners, they just kind of look like have darkness around the eyes. And then central facial pallor, and pityriasis alba, so those hypopigmented patches that our patient Daniel had on the face, is a pretty good sign of eczema. And that's common, actually. Sometimes that's the only thing the kid has. So we see that as pretty common. Prominent anterior neck folds. Keratosis pilaris is a stigmata of eczema. So you get and it's really common in the general population as well. But so the keratotic follicular papules, often on the backs of the arms, but it can go down the arms. It can be on the face, sometimes on the legs. Excoriations, of course, they're itchy. So the itch with atopic dermatitis can be really intense. So oftentimes they're scratching. Changes in pigmentation at sites of previous eczema. So that's pretty common. Follicular prominence looks like goosebumps. Trunk is the most common place to see that. Hyperlinear palms and soles. That's another stigmata of atopic dermatitis. Xerosis and ichthyosis vulgaris is the kind of a scaling that you can get on the lower legs. The atopic march, so our patient has asthma as well, and it's really common to see. I always ask any history of asthma or seasonal allergies or allergic rhinitis, because those often all go hand in hand. And some of our treatment options overlap and can treat both. So it's important to know what all they have going on. So atopic march is it kind of describes the onset of the different conditions. So often atopic dermatitis is the first thing that you notice. And as you can see, it takes a little bit, maybe a few months to become active. And with age, it often gets better, but as you can see, not for everybody. So there's still percentage of patients that it will be persistent. Food allergies, this is a very controversial topic, and we tend to not, we don't overemphasize food allergies, I guess, in dermatology. We don't believe that it's, if I always tell patients, if you truly see, that certain foods, you have the reaction, you notice a temporal effect, then maybe, but oftentimes they'll come in having eliminated eggs, dairy, wheat, milk, whatever, and the patient, like, what can they eat then? So it's controversial, and the parents are kind of grasping at straws, just trying to figure out what they can do to help their kid. But often food allergies are not triggers of eczema. They can cause other types of allergies, but and then asthma a little bit later onset, and rhinitis, so the seasonal allergies again. So that's kind of the called the atopic march, and so all those things go hand in hand. Okay, and then I'll take a second to answer this question. It says, you stated the race of Daniel. Why or how does that affect what diseases someone might get, their diagnoses, etc.? So for eczema, often so it is slightly more prevalent in African Americans, and can be more severe. So there's certain differences in the lipid barrier and whatnot. So it is just I tend to see it maybe more in African American patients, but all races can and do get atopic dermatitis, and have varying, levels of severity. Oftentimes the pigmentary effects are much more prominent, of course, in skin of color, because there's more natural pigment there that can change with inflammation. And I just really wanted to show that example, because not everything is red in all skin types. So it's important to be able to see the inflammation on different types of skin. So, okay. And then, okay, so a little bit more about what I would do for him. Usually on that first visit, I spend a lot of time going through the reasons that atopic dermatitis happens. So explain, it's inflammation plus that barrier function and that, water loss and hydration loss. So you can't treat it without addressing both of those issues. So going through a good skincare regimen, what good products to use, is very important. And I always say that's kind of the first step and the base of everything. So, spend a lot of time on that. Topical steroids, that targets the inflammatory component. So those are an important part of treatment. Potentially considering steroid sparing agents, which we often do in patients with atopic dermatitis, because this is a chronic issue. So we want to have patients use the steroids when necessary, and not be scared to use them, but have something else on board as well to help, so that we can minimize using steroids as much as possible. And then I don't go into this usually on my very first time meeting someone, but in my mind, I'm like, well, this is pretty severe. We're going to need, consider systemic treatments. We might need to consider systemic treatments. And I might throw that in there, like, let's give this a try first, but just know there is a next thing. So don't, get frustrated too soon. And then secondary impetigo. So education on why this happens. For this patient, he would need antibiotics to treat the pathogenization, and then ways to prevent that in the future. And one of which is a bleach bath. So patients kind of sometimes look at me funny, but you add a little bit of bleach, like 1/8 or 1/4 cup to bathtub, and that decreases some of that staph and whatnot. Fixing the skin barrier and treating the eczema is that in of itself is a way to prevent the secondary infection, but there's other, important ways to do that too. Sometimes they need to have little mupirocin on board if they get an open sore or something. So we talk about that, especially with kids. And then pruritus. So histamine is actually not a major driver of eczema or atopic dermatitis. So we use antihistamines, particularly if they're having the trouble sleeping. So hydroxyzine is kind of in the family with Benadryl. We'll use that just to help them sleep, and it just helps calm the itching. But really, our other treatments, treating the atopic dermatitis is going to help with the itching. And then a couple more questions. Have you seen many cases of atopic dermatitis leading to very bad infections leading to sepsis? Yes, unfortunately, this can happen. When I haven't, not since I've been in practice, which has just been over a year, but when I was in residency, we did have some severe atopic dermatitis cases that led to needing IV antibiotics and getting hospitalized for sepsis, and bacteremia really is what a couple of patients, they get the bacteria, gets into their bloodstream. So yes, that can happen for sure. And that's really pushes you towards needing systemic treatment because that's life-threatening. And then, let's see. And then another thing that can happen that I didn't go into is you can get herpes infections on top of eczema. So eczema herpeticum, when that skin barrier is all open, and you can get shingles or even like the cold sore virus, all on big parts of your skin. So that can be a major issue too, and we've had to hospitalize patients for that. And then, are there any negative long-term effects of steroid creams like desoxymetazone? So potentially, yes. So if they're used appropriately, the long-term effects are, the risk the benefit can outweigh the risk. But some risks of steroid creams using them chronically are thinning of the skin, lightening of the skin. Rarely, so if they are used on large surface areas of the body, certain steroid creams can be absorbed, and that's not a major concern for most patients, but technically that's a risk. Mostly it's localized, like skin thinning, or which is called atrophy. So that can happen. Okay, so then, because this is virtual, we have the ability to fast forward 3 weeks. You've gone through a good skincare regimen, how to use his topical steroids, and you treated the skin infection. And so 3 weeks later, and often I don't want to overwhelm mom or dad with too much at one time. So I'll have the close follow-up sometimes to just say, okay, let's calm down this flare. And then see you back, and we'll talk about maintenance and like how to transition from flare treatment to maintenance treatment, because you always pretty much always have to treat atopic dermatitis in some ways, depending on the severity. But so that his skin on his ankle has healed, his rash and his itching are overall improving, and he's sleeping better. So they're happy. So now what? So now you can go into more details about a maintenance regimen, and that is when you really want to push for steroid sparing treatments. So this is a nice just representation of 2 ways. So if reactive treatment, so you're going okay, but you flare, so you use topical steroids, you calm it down, and then you flare again, and just cycles and does that over time. Proactive treatment is, okay, well, you have a flare. Okay, well, we calmed it down. Now let's switch to a maintenance treatment that's going to be make those flares less frequent, less intense, and more manageable. So you might add a TCI, which is a topical calcineurin inhibitor, Protopic or Elidel, pimecrolimus or tacrolimus. Those are options that are not steroids, but they're anti-inflammatory. So you might use those and then just use the steroid twice a week, or use that twice a week. There's different ways you can do it, but it makes it more manageable over time. And then educating. So now how do we prevent these skin infections from happening again? How do we avoid triggers, or how to note triggers, whether it be, often it's fragrances or grass, or, being sweaty or whatever. So just trying to help them do what they can to avoid triggers. Not always possible, but you can talk about it. And then come back every 2 months or so, and for 3 months, you just make a plan for routine follow-up. And then if things are not better and you can't manage with topicals, I have a pretty low threshold for systemic medications, because this is a pretty miserable, the itch, the risk of infection, all that. If it's not controllable, you can go to oral treatments, which we'll briefly talk about in just a second. So infantile atopic dermatitis, just some more pictures. So this is on, different skin types, but face is sometimes super involved in kids. In childhood, again, the flexures, hands, and this is lichenified, so it has those textural changes. And in adults, again, lichenified, so scratching, lichenification. These can be called little prurigo nodules, so little from scratching, prone to prurigo nodules. Just another way to assess chronicity when those things are present. Okay, so treatment options. Definitely you need a good moisturizer regimen. Topical steroids, calcineurin inhibitors. Crisaborole is a newer topical agent. It's a PDE4 inhibitor. Light therapy is an option depending on where you live. And sometimes you can get a home unit for light therapy, but that's not super easy to do sometimes, but it's possible. Systemic treatments, so oral treatments, methotrexate, cyclosporin, mycophenolate mofetil are pretty commonly used. They're more general, technically immunosuppressants. So there's a lot of lab monitoring involved and follow-up. And then most recently, dupilumab, which is Dupixent, has come out, and that targets the receptor for IL-4 and IL-13, and it works wonders for a lot of patients with eczema. Medicine is moving towards more targeted treatments in a lot of different fields, and dermatology is definitely one of them. It's an injectable medicine, and it's approved now down to the age of 6. So for our patient, he's 4. Unless you got it off label, he wouldn't. You might have to use some of the other agents if he needed systemic treatment until he turned 6. Okay, what does light therapy do? Light therapy decreases inflammation in the skin in a couple different ways. It decreases the certain cytokines and certain the Langerhans cells, and so we use it for various. Use it for eczema, atopic dermatitis, psoriasis, and certain other conditions. So it's nice because it's not an oral treatment or anything. There's no side effects besides very rarely a burn or something. But it's a neat thing for sometimes. And are you taught the different ways that different skin colors react, or did you learn that from experience? Both. Both. I mean, there's more of a push towards diversity in dermatology, which is very important. I mean, it's kind of a given, but it hadn't been as emphasized until recently. And, you know, I trained at Tulane, and we had a diverse patient population. So we got to see, we learned during residency. So yeah, that's in both. And we always learn from your patients. So, okay. Next patient. Sorry, I'm blabbering on. Is we'll go. This is just the only other case I have. So, next patient. So we kind of went through, for Daniel, went through how he presented, how you got him under control, and then got him on a maintenance regimen. So you're going to be seeing these patients in follow-up. So these are chronic conditions. So, but that's a pretty typical case. All right. So next patient, I'll just skip to the HP, or, you know, the, HPI. So Mr. Smith, 33-year-old Caucasian man, 5-year history of an itchy rash on his elbows and knees, and more recently also involving the scalp. So he's tried over-the-counter moisturizers and Head and Shoulders, but he's not getting better. You look at his medical history, his family history, medications, allergies, and you go talk to him. So during the visit, he's really had a rash on both of his elbows and knees for about 5 years, but he hadn't really been too concerned with it. But this year it started, his scalp was starting to get itchy and flaking, and he can't hide this. So he feels embarrassed, and he wants to know what he can do about it. And he's only done over-the-counter moisturizers. So he's treatment naive. You get some other details. He really doesn't have a family history that he knows of, but his mom does have an arthritis, but he's not too sure of the details. And then when you review his review of systems, he also is having some joint pain and stiffness in the fingers and wrists. And he's only 33, so that's a little, you know, that should stand out a little bit to you. So you do his exam, and so you get a feel for his general appearance. You'll do a skin exam, and then we'll go into why, but you'll look at his nails and his joints. So yeah, his scalp, there is a lot going on, well demarcated. So this is an important observation in certain conditions, but you can see, I mean, normal rash. So it's well demarcated. Erythematous, so you can see the underlying bright pink color. Plaque means you can feel it. And it has something called ostraceous scale. And that means that it looks like an oyster shell. So it's just really thick scale. On his elbows, you see these erythematous, so they're in color. Psoriasiform is one way to describe the appearance of this. Thinly scaling plaques, so the scale is just a little bit thinner, and you got some pinpoint bleeding going on too. On his lower extremities, again, they're well demarcated erythematous plaques, and you have that very thick ostraceous scale. And his nails, there's some changes going on. These nails, there's a lot of terminology involved in nail findings, but this is called an oil drop. This is called pitting, where you have literally little pits. Onycholysis means the end of the nail is coming up. So that's not normal. Crumbling, maybe you could call this crumbling, where the nail plate starts to become like crumbly, crumbles off. And discoloration, of course, it's like yellowing and whatnot. So there's a lot going on in that nail, and that tells you a lot. So, and then, he mentioned his joint pain. So you kind of you feel his hands and his joints, and he does have some tenderness overlying the DIPs and PIPs. So the distal interphalangeal joints and the proximal interphalangeal joints. So he also, you kind of feel around on some of his other joints, and he does have some tenderness when you press on his Achilles tendon near where it inserts into the heel. This diagram is kind of nice. I mean, you can't always rely on this, but certain types of arthritis, certain inflammatory arthritides affect certain joints. So psoriatic arthritis, reactive arthritis, osteoarthritis can present in these joints. Different types of arthritis here. The metacarpal joints, that's pretty classic for rheumatoid arthritis. So yeah, it's certain joints give you certain clues depending on what's affected. Okay, so this is an easy question, but do y'all know what this is? And what he might have? I'll go ahead and I'm just gonna skip to the differential, and we'll kind of walk through a little bit of that. So psoriasis. There's also a condition called seborrheic dermatitis, which is if you saw kind of some flaking in the scalp and some redness in the scalp. But once it gets to be that thick of scale and that red and extending down onto the neck, I mean, that's a little bit more than just regular old seborrheic dermatitis, which is more on the spectrum with like dandruff. And of course, since he has other areas involved, nail findings, joint findings, that wouldn't go with seborrheic dermatitis. You could consider eczema, different types of eczema, and you could also consider fungus. So there are times when you have an infection of the scalp. So that's called tinea capitis, body, tinea corporis, and tinea unguum, when the nails are affected. So these are, this case is a little bit more clear that it's psoriasis, but there are times when you wonder, could this be fungus? So especially when just certain areas or the nails or whatnot are involved. So that's a pretty, that's not an uncommon scenario when you might be considering both. Okay, so his type of psoriasis is called plaque psoriasis. I'll show you some examples of different types of psoriasis later, but plaque psoriasis is the most common kind. Joint pain, and I would say he has probable psoriatic arthritis. You have to do some more evaluation, but based on that, he has psoriasis, has nail changes, and has, which the areas that he has involved would suggest it's probably related to his psoriasis. And then he also has nail psoriasis. So all those findings are considered nail psoriasis. Okay, so what's happening in psoriasis? This is incredibly simplified. We've really, we know even more about the pathways in psoriasis right now than we do for atopic dermatitis. We're getting there, but it's incredible what we know, what they figured out, people have figured out. Okay, so unknown trigger, underlying genetic predisposition is the case for most conditions, honestly, but and then some sort of trigger, you get a stressed keratinocyte, it activates part of the immune system, and then you get activated T cells. Th17 has really become a major player in psoriasis. So these, and then you get kind of a cascade, and it just kind of snowballs, I guess, and you get more and more and more inflammation. And then there's an interaction between T cells and the keratinocytes, and they then start to divide. And so you get the thickness, the scaling, they're reacting to the inflammation and all the cytokines present. So it's auto-inflammatory. We don't consider it autoimmune because you're not targeting anything of your own, but it's an auto-inflammatory, your immune system is just kind of going crazy. This is a neat little diagram as well. So again, it's even more complex than this, but you have all these different interactions, all these different cytokines, and we listed under here is medications that we have for each of these components of the pathway. So we can target TNF alpha, tumor necrosis factor alpha, with adalimumab, etanercept, and infliximab, and these are kind of the older medicine. Older, I mean, not that old, but and still great medicines, but they target the beginning of the pathway. And then as we've figured out more specific and further down the pathway and getting more specific to what's really driving the psoriasis, they've developed IL-17 inhibitors, IL-23 inhibitors are the newest ones. So it's, there's a lot going on, a lot of inflammation, but we've gotten some pretty good treatments because they've figured this out. And then psoriatic arthritis. This, psoriasis is one thing. Of course, you don't want that on your skin. It's uncomfortable. It's itchy. It's embarrassing. But psoriatic arthritis can be very debilitating. So we really want to screen for this in all your patients with psoriasis. Up to 30% of patients will have it. And when this is present, you really want to go towards a systemic treatment if the patient is up for it, because you get joint destruction over time. And that's not, once it happens, it's not reversible, but our treatments can, halt it. So when you're considering psoriatic arthritis, of course, your patient as a dermatologist in front of you will have psoriasis. So, but if say you were a rheumatologist seeing a patient with joint pain, you would ask about, well, do you have psoriasis or a family history of psoriasis? Because you would be considering psoriatic arthritis. Sometimes the arthritis presents first. That's less common. Usually the skin presents first, and later on they might develop the joint symptoms, but sometimes they have no skin psoriasis, which is tricky. You look at the nails. You can do rheumatoid factor. So that's actually one of the criteria that you look for is that negative. If it's positive, then you're considering rheumatoid arthritis. And this would be, sometimes I do this, but oftentimes it's in conjunction with the rheumatologist. Dactylitis, which means acute swelling of a toe or a finger. It's called a sausage digit. And then if you see radiographic evidence of psoriasis, like psoriatic arthritis or enthesitis, that is also part of the diagnostic criteria. Most often it's a asymmetric oligoarthritis, meaning it's different joints, and it's asymmetric and it kind of moves around. Maybe last year their knee kept swelling up and this year it's their fingers, and it can kind of behave like that, whereas certain other types of arthritis might be more symmetric. Okay, so for him, Mr. Smith, you would diagnose him with plaque psoriasis, talk to him about it. You would start with topical steroids, but in him, because he has, more widespread, so probably in the moderate severity of psoriasis, and because he has joint pain, which you could send him to a rheumatologist for further workup as well. But really, you're kind of going to head towards down the line of systemic treatment. You could do blood work. You do have to do blood work to monitor, to evaluate for any underlying issues, or you check, for example, like a tuberculosis test. Certain biologics can make you more susceptible for tuberculosis reactivation. Less common of an issue in the US, but still possible. You have to screen for that. You screen for any history of hepatitis. So if you start a patient on a biologic that has an underlying chronic hepatitis, that hepatitis could then get out of hand. So you have to be careful, and you have to know their comorbidities and know what to screen for. So of course, I'm very much oversimplifying it, but that's part of your thought process. And then for nail psoriasis happens because parts of the nail matrix, nail bed, those have psoriasis active in the cells. So you get the changes of the nail plate because of that. And you can try topical treatments such as topical steroids. They're pretty underwhelming. How, you know, they don't work as well as you would hope. So oftentimes you treat the systemic treatment helps with the nail psoriasis. So because you're treating him for other things, hopefully you would hope once you get him on systemic treatment that the nail psoriasis would improve. So more examples. So plaque psoriasis, bright red, well demarcated again. This is more scaly. This is, again, so in a darker skin type, you would have more violaceous appearing, but that's, you know, that's psoriasis. And then guttate psoriasis is another form of psoriasis. And that is, guttate means like these little spots of the psoriasis. So rather than larger plaques, it's and it's often acute and it kind of just flares up. It really freaks people out, the patients. It's usually younger patients, not always, but I feel like I've seen a lot of like 20s and 30-year-olds that there's often, sometimes you can identify like a strep infection that has triggered it and you treat that, and often this can go away. Sometimes they go on to develop true plaque psoriasis and sometimes they don't. So you just, this is just a different type of psoriasis. Inverse psoriasis, so it affects, so it's inverse, affects the skin folds. So under the breasts and the axilla, groin, that's another place to see psoriasis. And then some pictures of psoriatic arthritis. So the last one was just like a cartoon, but this is a real picture of dactylitis where you have this, it's literally called a sausage digit, and that's acute inflammation, painful. And then the end result sometimes of psoriatic arthritis, which this happened more frequently in the past when we didn't have as good treatment options, but this is what you don't want to happen, is the deformities that can result. You get resorption of the bone and digits or in the joints, just really can be really debilitating. So now that we have such good treatment options, we hope and try to prevent this from happening. So a lot of treatment options, can't really go over every one, but topically, and you might just use topicals if it's limited psoriasis, but if it's more widespread, it's a little bit harder to get creams everywhere. But some people, you just have mild, maybe just their elbows are affected or something, and they're happy with just creams. So topical steroids, vitamin D analogs, and retinoids are commonly used. Light therapy, again, so it just decreases that inflammation. It can be very effective in some patients. Systemic treatments, so again, so methotrexate and cyclosporin, you remember those are also used in atopic dermatitis because they are just kind of broad they just decrease inflammation, not anything, there's nothing really specific about them. So they can be used for a lot of different conditions. Retinoids, oral retinoids can be used, like we use Accutane for acne, but there's something called Soriatane that's similar. It's a retinoid, vitamin A derivative, and it just helps that skin kind of normalize rather than thickening up. So that can be used. It does not address the joints, so it would only be used for skin psoriasis. Apremilast is a PDE4 inhibitor, and that's an oral treatment, so it's a pill. That's considered an immunomodulator. So that's an option for kind of the moderate category. And then there's a long list of biologics, and these are the ones that are approved for skin, and some of them are also approved for joints, but really you're targeting both because the inflammation is really the same. So etanercept, infliximab, adalimumab, those are TNF alpha inhibitors, and those are been around the longest. Ustekinumab targets IL-12 and 23. secukinumab and ixekizumab and brodalumab target IL-17. Guselkumab and risankizumab target IL-23. So that all were in that pathway. So we have a lot of good options, which we're fortunate. Okay, so, and then one question that came through was, how would you test for fungus? So if you were ever not certain of your diagnosis, you could always do a biopsy. Oftentimes with psoriasis, you don't have to. It's usually a clinical diagnosis, but if I do sometimes, if it's not clear, you can easily do a little skin biopsy. You can also do, if you thought it was more fungal, you could do a scraping and look under the microscope and look for fungus there. So that is how you would do that. Okay, and then I said this last time and just say it again. When you're going through pre-med classes and all the extra stuff you have to do to get to the next thing, which is med school, and then we're going through med school to get to the next thing, which is residency. You know, it's a path, it's a long road, but if you remember your reasons for doing it, that I find super helpful, and it's a very personal thing. So remember your why. And then picture credits, and then thank you. There's 2 more questions that came through, but feel free if you have any other questions, send them through. Can intense labor with the hands and feet cause arthritis? Yes. Well, like wear and tear arthritis with like people who spend their life with doing physical jobs or whatnot, yes, can get more predisposed to osteoarthritis. And oftentimes with inflammatory type arthritis, you can kind of, it's worse actually after periods of inactivity. So after sleeping and when you wake up, it might be worse. And then whereas osteoarthritis might be worse at the end of the day after you've been using your joints all day. It's not always exactly clear cut, but those are kind of clues when you're talking to a patient. And then the next question, if a patient develops eczema on the genital area, would they be referred to a gynecologist or a dermatologist? We see genital rashes and issues. So I think that they would refer more so to a dermatologist. It probably depends on what exactly it is, but I think if it's eczema, then a dermatologist would probably handle it. But a gynecologist, oftentimes women are seeing, if they see their GYN regularly and they have a genital issue, they'll bring it up to them, and they're very good at treating. And if they think it's something unusual or can't get it under control, then they might refer as well to a dermatologist. So it just depends, but maybe some of both. And then how do you treat patient whose skin has gotten dependent on steroids? So that is, trying to see if I understand that question. So if you're dependent on steroids, meaning like if you don't use your steroid, whatever rash you're having comes back, then I would still try to introduce steroid sparing agents if possible, meaning things that are not steroids but would still treat the condition, or systemic treatments if it was really just not able to be controlled with topical regimen. I think that might be what you mean. Is it possible for psoriatic arthritis to be externally controlled, but for the arthritis component to continue worsening over time, unbeknownst to the patient? Yes, good question. That is possible. So usually there's joint pain, and patients sometimes try to minimize the joint discomfort or whatnot. And for example, if a patient has mild skin psoriasis and I'm able to give them topical treatments and they're good, but they're having joint symptoms, I'll get a rheumatologist involved to do some more digging. You can check inflammatory markers and even do imaging if there was any concern that the symptoms kind of were less than than what was actually going on, and then let the rheumatologist decide if they need systemic treatment. So if they don't qualify for systemic treatment from a skin perspective, then the rheumatologist generally will be not always, but usually will be the prescriber and manage the joint symptoms. And sometimes it depends on where you are, like if you don't have access to rheumatology or and how comfortable the dermatologist is, and vice versa, a rheumatologist with managing the skin. If their joints are under control by the rheumatologist, but they can't get the skin under control, then they'll send them to us. But often it's a team effort, and to really tease out arthritis, sometimes the rheumatologist is that's their specialty. So they're get on board for that. So. All right, is that everything? A little hour and 15 minutes, so.
Thank you so much, Dr. McKay. This was such a wonderful presentation. Everyone learned so much from it. Thank you so much again for taking the time to do this. For everyone watching, the Google form to track attendance has been posted in the YouTube chat box and will be posted in the Instagram bio shortly. You'll have 30 minutes from now to complete it. So it'll close at around 11:47, 48. And thank you so much again, Dr. McKay, for